And I have the pleasure today of being able to introduce two of my team members. So I'm really, really excited. First, Dr. Peace Dike is a clinical assistant professor in the Division of Gastroenterology, Hepatology, and Nutrition within the Department of Pediatrics. She serves as a Health Equity Rounds faculty co-lead, Office of Child Health Equity Policy co-lead, and interim faculty director in the Office of Diversity, Equity, Inclusion, and Justice. Her scholarly work is aimed at addressing structural racism in transplant populations using live health equity dashboards and determining psychosocial barriers in the pre-transplant process by partnering with patients, families, and community engaged partners. At our past institution, she partnered with state and local organizations such as the Texas Liver Foundation to create programs and ensure health education and initiatives were a priority in underserved communities. She's also facilitated discussions centered on diversity, equity, inclusion, and justice and health equity issues, including LGBTQIA+ rights, sexual education, anti-human trafficking, nutrition education, and liver health-related topics. Here at Stanford, Dr. Dike is leading community-based research to engage the community and families with our transplant team to improve healthcare outcomes for Black and Hispanic children. She also serves as a faculty mentor in the Stanford Medicine Leadership Education and Advancing Diversity Program, or LEAD program. Dr. Shamita Punjabi is a clinical assistant professor in the Division of Neonatal and Developmental Medicine in the Department of Pediatrics and works as a neonatal hospitalist in the Intermediate Care Nursery and Pediatric Hospitalist in the Stanford affiliated community sites. Dr. Punjabi currently serves as a Health Equity Rounds faculty co-lead, and during her time here at Stanford, she's demonstrated a commitment to diversity, equity, inclusion, and justice, working aside her colleagues in the Intermediate Care Nursery to develop a grant-funded, action-based health equity curriculum for trainees, which has been recognized and shared across pediatric institutions nationally. She serves as a faculty co-developer and facilitator for Health Equity Rounds in the Division of Neonatal and Developmental Medicine since spring 2022. And additionally, she served as a HEAL Anti-Racism and HEAL Microaggression Seminar Facilitator from 2021 to 2023, and also serves as a faculty mentor in the LEAD program. And so with that, I'll give you Drs. Dike and Punjabi.
Good morning, everyone. Thank you so much for having us here today. Thank you, Dr. Floyd, for that introduction. My name is Shamita Punjabi, and I'm here with Peace Dike as the faculty leads for Health Equity Rounds to present Health Equity Rounds in action for the Department of Pediatrics and Stanford Medicine Children's Health. During the session today, we hope to increase the audience's knowledge of our current HEAL initiatives focusing on health equity rounds. We will highlight an example of division-specific health inequities which led to system-level changes, and lastly, identify the next steps in achieving health equity-informed systems-level changes.
Before we get started, we'd like to start with a historical context of health inequities within the United States. In 2003, the Institute of Medicine released Unequal Treatment. It was the US's first detailed and systematic examination of racial and ethnic disparities in health outcomes. The authors of the report concluded that racial and ethnic disparities stem from historical and contemporary systemic biases, prejudice, stereotyping, and economic and social inequality. Also, these authors outlined a plan to address these identified barriers. However, the events of 2020 emphasized that systemic change had yet to be actualized. The COVID-19 pandemic and the killings of George Floyd, Breonna Taylor, and others brought an increased visibility to the disproportionate health outcomes amongst Black, Latinx, Indigenous, and migrant communities due to longstanding socio-political inequities, unequal access and quality to healthcare, and medical mistrust stemming from years of medical abuse and exploitation and police violence, resulting in higher rates of morbidity and mortality amongst these groups. The combination of these events heightened the urgency within our medical community to not only identify the structural and systemic barriers embedded within our system, but really created a call of action amongst healthcare professionals, our healthcare system, and policymakers to challenge and dismantle the systems that have produced and sustained these inequities. In alignment with increased visibility of anti-racism social justice movements of 2020, the healthcare community responded both on a national and local level with social movements such as White Coats for Black Lives and our own institution's faculty and staff-led Stanford Pediatrics Advancing Anti-Racism Coalition, or SPARC, which aimed to promote a culture of anti-racism and develop targeted anti-racism interventions within the Stanford Department of Pediatrics. However, before moving on, it's impossible for us to look ahead without acknowledging the present attack on diversity, equity, and inclusion that continues to extend into healthcare. From attacks on state-level medical boards that require implicit bias training and inclusive recruitment policies, to eliminating anti-racism initiatives within governmental health agencies, and directed attacks on healthcare access in the LGBTQIA community, such as restricting or banning gender-affirming care, and recent executive orders and actions on immigration and citizenship that poses a threat to previous safe places like hospitals, making healthcare inaccessible to historically excluded groups and further widening the healthcare inequity gaps. So again, before moving on, we wanted to take a moment just to hold space and acknowledge the tension that many of you all who are champions in these efforts may be feeling during the current climate. But also, we wanted to also reinforce our team and our institution's commitment to a continued advancement of health equity in spite of the current resistance.
In light of mounting visibility of continued inequities on local and national levels, the Office of DEIJ, in collaboration with the Department of Pediatrics, continues to honor their commitment towards prioritizing action-based equity education and solutions for faculty, staff, and trainees. And we wanted to take a moment and highlight some of these initiatives here. So to remind us all, Health Equity Round sits within a paired educational model as part of the HEAL initiative, which also includes our HEAL seminars. Many of you have participated in the HEAL trainings, which are educational workshops intended to provide foundational DEIJ knowledge in various topics, while offering action-based strategies to build more inclusive work and learning environments. Health Equity Rounds builds on these trainings and further encourages us to apply foundational concepts to understand how bias, oppression, and systemic barriers affect specific patients that we care for, and how we can use local level tools to mitigate these inequities in care. So to help set the stage for our discussion today, we wanted to share a health equity educational framework that helps us contextualize health equity rounds within the landscape of DEIJ education that we receive at Stanford. So first, providing equitable care to our patients requires the intentional effort on behalf of individuals, local teams, and institutions. We each need to do the work to become anti-racist. We want to ensure we are growing to the point where we can sit with our own discomfort, speak out when we see racism in action, and then, as we do with so many things in our profession, continue to educate others and to change our clinical practice. So how do we have these consistent conversations where we can recognize inequitable care, challenge and disrupt our comfort zone, and practice actionable steps to mitigate inequities? This framework by Soto Santiago et al. Provides guidance for developing anti-racist practitioner educators. So our HEAL seminars provide the foundational knowledge and awareness in the first two tiers, while the Health Equity Rounds fits into that middle tier. Health Equity Rounds provides a forum which allows us to put this education into practice, focusing on specific case-based discussions, exploring issues of inequity, which then fuels ongoing conversations with clinical teams. Health Equity Rounds helps us by building cultural humility and centering equity-focused QI work, which leads to dismantling of bias structures and practices.
And so we describe the format of health equity rounds in our subsequent slides, as well as our approach to health equity. A common approach to health equity has been an overemphasis on characterizing health disparities, which is a related but distinct concept, but often used as a proxy for measuring health equity. However, disparity only provides a limited scope by only measuring health outcomes. Rather, with health equity as a focus, we measure the social experiences of social exclusion, taking into account the social determinants of health to understand the outcome. Thus, in our health equity rounds, we focus on the intent of examining the root causes and focus our goal in developing targeted solutions to address these root causes of inequities. So health equity applies a structural competency lens to clinical care and quality and process improvement to address inequities in a multidisciplinary way. We strive to build accountable spaces of collective sharing and responsibility in addressing challenging topics and collaborative partnering to formulate real systems change. So how does this look? Our health equity rounds are case-based discussions where we explore issues of equity that present in our medical settings. We review relevant literature and the historical context of these health inequities, and then include evidence-based personal bias mitigation strategies with the goal for individual level practice changes to inspire local level systems change.
The goal of each health equity round session is to formulate an action-based QI goal using the SMART framework, which may look familiar to many of you. Adding an equitable and inclusive revision to your SMART goal will ensure that your goal is not perpetuating inequities that already exist in the system. As an example, consider this example SMART goal. Within 1 year, decrease discharge delays due to medication clarifications by patients and families by 20% using a novel discharge medication management toolkit. So if we don't consider the health literacy of our patient population, consider who may or may not have access to necessary technology as applicable, or do not consider non-English speaking families or all of the above, then our SMART goal and project will be continuing to perpetuate inequities. So we can revise the SMART goal to have an equitable and inclusive focus so that includes all families regardless of primary language spoken. And this will ensure that we're continuing to keep all families at the forefront of the outcome and recruiting the support of necessary partners, such as interpreter services, for example, in accomplishing our goal. So over the last 3 years, we've seen consistent engagement in health equity rounds, both across the divisions within the Department of Pediatrics and across Stanford Medicine Children's Health. And all of these are divisions that have participated in health equity rounds over the last 3 years. There are 9 that have done at least 2 years, with 8 divisions having done 3 years of participation. Several clinical groups have also taken an independent approach to facilitating health equity, not only health equity rounds conferences, but also other health equity initiatives, such as health equity focused journal clubs or health equity clinical check-ins.
So how do we measure our impact, and specifically in the last fiscal year? So we actually measured our impact in 4 domains, with participation and engagement, knowledge acquisition, skills building, and implementation and process change. The figure on the right shows the multidisciplinary participation that we had within the sessions. And as you can see, the majority of our sessions were attended by faculty physicians and physician trainees, making up roughly about 3/4 of our participating divisions. However, I would like to call attention to our 3rd largest group that's designated as other. And we really did include the expertise and the partnership from groups or individuals like our advanced practice providers, dietitians, pharmacists, psychologists, clinical managers, and staff, and that really enriched our sessions. To be able to assess knowledge acquisition, we surveyed the level of comfort pre and post our health equity round sessions. As you can see in this figure, we noted approximately 15% increase in the level of comfort reported by participants in discussing health inequity topics, with greater than 96% of participants reporting feeling somewhat to very comfortable in discussing health inequities after attending our sessions. We further assess knowledge acquisition by assessing participants' perceived educational value of these sessions, and we had roughly 91% of participants rate the health equity round sessions as good or excellent in rating. In order for us to assess how participants built skills, we surveyed the acquisition of personal strategies such as bias mitigation strategies acquired after attending our sessions. And we saw that about 88% of our participants reported identifying strategies to mitigate bias after attending our health equity round sessions. And finally, we assess participants' implementation and practice changes by surveying the likelihood to change practice, and saw greater than 97% of participants agree that health equity rounds would improve their practice, and 100% of our participants reported that the ability to identify systems improvement changes needed to implement this practice change and address health inequities.
Over the last year, we took a look at all of the different themes that the divisions had discussed during their sessions, and we categorized them into these various domains by which they play out. So the first is language access, ensuring families with a primary language other than English have access to the same high quality care as families with an English primary language. Examples of this may include discharge teaching with in-person interpreters and MyChart activation for families whose primary language is not English. Additionally, resources and infrastructure was a very common topic that came up. So this includes optimization of existing resources to provide equitable access to care. This might include understanding how an existing interpreter services structure can meet the needs of teams and where there are gaps. Care coordination was another topic that arose. So organizing workflow between staff and providers to ensure safety nets for families who are medically and socially complex. Supporting families in Medi-Cal enrollment outpatient might be an example of this, or systematically following up on patients who miss appointments. And finally, culture and practice was a big topic. So prioritizing individual and team-based practices to create a cultural environment that is inclusive of all identities and removing bias. So some examples of this may include removing stigmatizing language in our charting, or mitigating microaggressions towards staff and patients, or creating a culture for staff, faculty, and patients that is inclusive of all gender identities and abilities. Our ultimate goal is to move beyond discussions and translate the themes of health equity rounds into clinical practice changes that improve local processes and systems. And this can seem really daunting, but with the cooperation of multiple patient care teams and services, it is achievable. We wanted to take a moment to highlight the work of our pediatric neurosurgery group at Stanford, who utilized an equity-focused QI framework within their health equity rounds to address inequitable care on their inpatient service. So we'd like to start off by sharing this illustrative case presented during their conference, one of the many cases that inspired the creation of their SMARTY goal. So they had a medically complex patient who was well known to the hospital, admitted for surgery. The patient was school-aged with a trach and is nonverbal, and the family's primary language is Vietnamese. They do not speak any English. There was a miscommunication that occurred within the rehab team when the family requested a walker for home, but a shower chair was ordered instead. The family did not speak up about the error, and when they were asked why they did not speak up, they responded, "This always happens. No one ever listens, so I stopped trying." So this is a really challenging case, and one that may be familiar to many of you on your subspecialty services or even in outpatient. There are several existing frameworks that delineate an approach to discussing barriers and providing equitable care. And during our health equity round sessions, we propose a modified version of these frameworks that describes 3 levels of barriers as it allows the teams to best triage their approach to addressing these inequities. Many factors in this case led to inequitable care, including individual patient and provider sociocultural factors, team-based factors, and then the broader systems level factors. And several of these factors may also span multiple levels on this pyramid. Some examples may include timely availability of interpreter services and additional challenges in interpretation for patients with a non-Spanish primary language. This discussion helped them target a realistic and attainable intervention that could impact the quality of communication around discharge planning. They created a SMARTY goal with an inclusive and equitable component, focusing on the use of in-person interpreters for greater than 60% of all discharge teaching between July and October of 2024, with a goal of greater than 80% utilization by December. The team demonstrated the components of a successful framework to achieving their equity-focused QI goal, which involves establishing equity champions, creating a shared vision within their team, and enacting tangible changes in their practice. Their champions included APPs to ensure interpreters were requested daily. They then presented their initiative and goals to their division, securing buy-in and ensuring that all members of the care team could participate in this intervention. And finally, they targeted 2 aspects of their clinical care workflow to facilitate visibility around modifying their inpatient list to include a language preference column and also adding a morning language rounds during sign out to request interpreters earlier on in the morning. So as with all QI initiatives, they faced 2 primary challenges which were interconnected. First was the variable rounding times of the surgical services. And secondly was the variable availability of in-person interpreters each morning, resulting in teams either having to wait for an interpreter or schedule time in advance. And then this was again sort of further complicated by the uncertainty in the surgical team's rounding schedule. Despite these challenges, an EPIC analysis of documented in-person interpreter usage showed that the team's bundle of targeted interventions resulted in increased interpreter usage from 0 to 52% within the calendar year 2024. This run chart demonstrates sustained changes in the provision of language concordant care over about 9 months. The impacts of these efforts were tangible, resulting in increased confidence in providing quality service to their patients with considerable comfort by both patients and providers when using an in-person versus an iPad interpreter. Hands-on teaching and learning resulted in increased understanding and feedback with the ability to teach multiple caregivers at one time, as you can imagine with an in-person interpreter. And they're also able to demonstrate more procedures with an in-person interpreter, given the opportunity for more live feedback and questions. And finally, as a result of these interventions, they noted fewer confusions and miscommunication in treatment plans and more families following through with instructions and recommendations at discharge. Our colleagues shared with us their takeaways from this QI experience, including one, the importance of teach back with families to assess quality of interpretation received and ensure that the discharge education was both understood and achievable for their patients. And secondly, that requesting an in-person interpreter earlier in the day will typically result in shorter wait times, which will help expedite the discharge workflow for their teams. So we want to thank our neurosurgery colleagues for allowing us to share their journey in equity-centered QI work, and we applaud their endeavors in improving language access for their families. It's a wonderful reminder for all of us that small incremental efforts can result in a meaningful impact while providing the confidence for both patients and families and providers.
As Shamita described, with the success of our last year and previous years in health equity rounds, we really want to think about how do we further expand our vision and how do we continue to move towards a more equitable vision for our patients. And so we reflected back together about our past year's intended versus actualized impact and the metrics that we traditionally use to determine how our sessions are being impactful and whether we are really moving towards that goal of equity, which we define as the fair and just opportunity for every child to be as healthy as possible. We knew that in our 2025 vision, it would require us to develop a systems thinking approach in order to build capacity amongst our participating divisions to create systemic, sustainable, and impactful change. This approach to systems level thinking highlights the complex and interconnected nature of system level issues and deepens our analysis and understanding beyond just individual problems, but to a more comprehensive synthesis of often closely related systemic issues. Systems thinking also highlights that sustainable change is best achieved when we de-silo our efforts and combine individual solutions to create whole system level changes with building relationships and capacity, while also embedding a culture and system of accountability and feedback loops to ensure that our equity goals are appropriate, relevant, and impactful. So using this systems level thinking, our HER team has aimed to empower our divisions to broaden past individual level metrics of success seen on the right that we discussed earlier and move towards metrics that measure impact on the individual and community level. In order to do so, our HER team will continue to utilize our HER educational session structure to embed anti-racism education and translate this education into practice to identify health equity gaps, continue to work with our divisions to set smart, inclusive, and equitable goals, and support our divisions in amplifying the individual efforts and equity projects that are being carried out. However, as you all know, in order for these proposed projects to have the intended depth, breadth, and the individual community level impact, our HER team plans to connect or to work towards connecting individuals and their divisions with individual health equity leadership and resources to continue to de-silo our efforts and ensure an alignment of relevance and impact across our institution. Moreover, as our institution is moving towards an equity-focused model of systems improvement, our team seeks to connect and align identified health equity-focused projects and health equity outcome metrics to institutional metrics via institutional dashboards, and connect those divisions with community-facing projects with institutional community partners to further strengthen our impact and relevance in our communities. And hopefully, as we've described, continue to move forward our vision of health equity amongst our patients in our communities. And we thank you all for your involvement. We know many divisions are represented here, even in the audience, who participated in our efforts, and we appreciate that. And we also want to just acknowledge our HEAL team, which is led by Baraka Floyd and Allison Guerin, who are in the audience, Emmett Griffith and Kate Jara. And then, as Shamita said, our division of pediatric neurosurgery, who was our champions were Stephanie Choi, Caitlin Bassnett, and Cormac Mayer. But I also want to recognize all of the divisions this past fiscal year who participated and really made a commitment towards moving towards health equity, and then other divisions of past. So we will take any questions.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.